Hi everyone, my name is Gabriel Altit. I'm a neonatologist based at the Montreal Children's Hospital. I run the NeoCardio Lab website and I run a research lab that is affiliated to the McGill University Health Center Research Institute. And today I thought it was important to go back to some of the basics with a case highlighting concepts related to acute pulmonary hypertension of the newborn, or classically known as PPHN, or persistent pulmonary hypertension of the newborn. I do think that this is a common case that we see in which we provide basic hemodynamics care and comprehensive cardiorespiratory care in a holistic fashion for the baby. As we know, these babies can be sometimes quite ill. But obviously it's a spectrum, and there are some babies with a bit less severe of a presentation and some with a more severe presentation that require much more advancement or much more escalation in care. And so here I'm going to review one case that is a classical one and give an example of some of the case reviews that we do when we do assessments for some of our patients in which we perform hemodynamics evaluations. Let's start. So I will share my screen. Um, Let me try to find my case. Perfect. Um, this is the case of January 2025. And I thought of starting these case reviews by video, which helps me a bit describe what we see on some of the images that we acquire in our evaluations. And so I'll start by saying that acute pulmonary hypertension, or PPHN, is its own particular condition of the transitional period where there's either a perinatal stressor, prenatal or postnatal, or during the process of the birth, in which case this stressor or multiple stressors are leading to an adverse transition of the newborn. Most often, we know that babies after birth will have a cascade of different events that happen in order to make them autonomous in terms of their breathing and their cardiovascular function. And so, for example, prenatally, we know that the placenta will act as the oxygenator for the fetus and gas exchange. And because of that, we know there's high pulmonary vascular resistances, which means that there's very low pulmonary blood flow, and that the right ventricle is contributing to the systemic output by getting oxygen coming from the ductus venosus that comes from the placenta. The ductus venosus will drain typically in the inferior vena cava that eventually drains into the right atrium. The right atrium will be shunting towards the left atrium via the foraminal valley, knowing that the left atrium is underfilled due to low pulmonary vascular flow and low pulmonary venous return. So because of that, there's a preferential right to left shunt. We also know that the RA receives also the systemic venous return. So obviously the RA pressure becomes a bit higher than the LA pressure due to the venous return from the placenta, venous return from the upper and lower part of the fetal body. So there's a lot of venous return to the RA, or right atrium, that eventually offloads into the LA. And then part of the blood flow coming into the right atrium will also fill the right ventricle, which will then be ejected by the fetal right ventricle. And the right ventricle will feed a bit of the blood flow into the pulmonary arteries, about 10% of its cardiac output, which allows for the growth of the pulmonary vasculature during fetal life. But the majority of its output will be going into the descending aorta through the ductus arteriosus, which is maintained patent by the secretion of prostaglandin by the placenta, as well as the ductal wall, and also by the fact that there's low oxygen tension. And so after birth, so this leads to a pulmonary to aortic shunting of blood flow during fetal life, or this right to left shunt at the level of the ductus, which is expected. And So we know that during the process of delivery, there's many mechanisms that happens, one of which is the acute drop in pulmonary vascular resistances that will continue to drop for the first 2 to 3 months of life. But this drop is mediated mostly by the fact that the baby will take a big breath, and so the lungs will expand like a parachute that opens. And so all of these walls of the alveoli will get kind of stretched out, and all these pulmonary vascular bed will open up within these walls. Um, at the same time, on top of the kind of mechanical events, there is exposure to oxygen, which is a potent pulmonary vasodilator, and which will trigger cascades of secretion of endogenous substances that will further promote pulmonary vasodilation. And at the same time, you eventually cut the placenta, which will dramatically raise the systemic vascular resistance. So the balance will make that initially the kind of duct will become bidirectional because there will be relatively equal resistance between the two systems. And as the PDA close, typically there is progressive transition towards a preferential left to right shunt at the duct, where the SVR are typically becoming much higher than the PVR. And because of the effect of increased pulmonary blood flow, the left atrium becomes more filled with blood. And eventually the right and left atrium have equal pressure. So you have a bit of a bidirectional shunt at the foraminal valley. And eventually you get a preferential left to right shunt at the foraminal valley because the LV faces higher resistances, and because of that, its end diastolic pressure becomes a bit higher because the muscle of the LV becomes more prominent to sustain the systemic output, and the LA pressure becomes slightly higher than the RE pressure, starting a few days of life of the baby. So that's kind of the normal transition, and this transition can be obviously very disturbed by stressors like lack of oxygen, perineal asphyxia, sepsis, infections, sometimes maternal medication, placental events, anemia, bleeding, cord events, resuscitation. So there's many elements that could, alter this smooth transition after birth, some of which are pulmonary lung disease, can also affect the drop of PVR. So, and because of that, these patients end up with relatively higher than expected pulmonary vascular resistances, less pulmonary blood flow, which can really disturb this whole cascade of event. And so, some patients may have a component of lung disease, which means that you can get what we call ventilation perfusion mismatch. So typically blood flow will go through the lungs, and if you have pristine lungs, you get great gas exchange, you get oxygenation of your blood, and clearance of the CO2. And whatever comes back by the pulmonary veins is typically extremely well saturated, unless you have some degree of lung disease, during which case you have areas of the lungs that may have red blood cells passing through and never meeting any kind of oxygen. And so it can come back by the pulmonary veins and be already desaturated. So the reason that a baby may be desaturated could be, of course, because of respiratory reasons or airway reasons sometimes, or a mix of it. And sometimes it could also be a component of, pulmonary vascular disease or cardiac conditions or shunt conditions. So we'll go with this case, which is really the case of a term baby who during the pregnancy was exposed to, some degree of hypertension and diabetes. And at birth, there were signs of meconium. And there was a, delivery by C-section in the context of failure to progress in labor, with possibly some decelerations. The baby was born, it required some support at birth, and eventually was intubated because was saturating in the very low 70s. And post-intubation, the baby was still on 100% oxygen, and was transported to our center and received surfactant without great response in terms of the oxygen needs. And on assessment, the baby at that time did not have any kind of differential saturations of oxygen between the preductal and postductal limb. And so obviously at that point, the clinical team was unsure, is this only like lung disease? Is it a component of high pulmonary vascular resistances? what is going on. The baby at that time had relatively good systemic blood pressure, 60 on 40, adequate heart rate, was appropriate weight for the gestational age, which was a term infant, with actually having adequate urine output, good pulses. And on my exam, there was no hepatomegaly. When I reviewed the case, there was no signs of marked acidosis, and they were able to actually ventilate appropriately, but on high frequency ventilation with a MAP of about 12. The PaO2 was in the 57, which made me think that there might be some degree of right to left shunting or deoxygenated blood entering the systemic circulation, either at the foramen ovale or a duct if it was still present. And so, because the arterial line was in the umbilical area, so we know it's a postductal sample. So it could be both influenced by a shunt at the cardiac level or at the level of the duct. Now, the fact that there was no pre and post saturation differences tells you that either there's no duct, or that the duct might be left to right, or that the duct, if has a right to left contributor, doesn't contribute to a huge volume of blood mixing into the systemic circulation. So if there was a residual duct, it was unlikely to be significant if it was indeed a case where PVR were higher than SVR, and that the RV was able to generate sufficient output. So this is what the X-ray looked like. The baby was intubated in appropriate position. This was the carina. The lung expansion looked adequate, but there was a lot of, kind of reticular nodular areas, maybe some areas that are a bit more opacified. So, query, could this be compatible with meconium aspiration syndrome? The baby at the time of evaluation was around 70 to 80% oxygen, and, frequently desaturating during manipulation. So the team had decided to start a bit of low dose kind of sedation for comfort and sedation analgesia. And at the time of my evaluation, we were at 12 hours of life. And so, I'm going to start with our usual sequence of images. So here, this is a parasternal long axis view. The first thing you can see is that you have the RV here that looks a bit, I would say, distended or dilated. The walls are expected to be a bit more muscular, considering that this baby is only 12 hours and that there's often an RV that is systemic during fetal life. So they're often a bit more muscular in the first few days of life. So that's not surprising. We see an aortic valve that is opening and closing, and we see, grossly part of the left ventricle with the mitral valve here in the left atrium. And there's, what looks to be a good approximation of the walls in systole and good opening of the mitral valve and the aortic valve, telling me that, at least grossly, the LV is not extremely affected by the condition. So then I do a sweep, my usual sweep from, going to the posterior area, eventually the middle, and then the outflow tract of the RV. So this is a tricuspid valve, RV body, or RV inflow section and body. And then eventually, as I go anteriorly, I see the RVOT, and then the pulmonary valve and the main pulmonary artery. And we see the pulmonary valve opening and closing without any problem here. So it's not a case of like pulmonary atresia or pulmonary stenosis. So here we've put collar. We see there's no marked AI. There's a bit of mitral insufficiency, which we often see in the perinatal transition period, especially if the baby had lived a bit of a stressor. We classically obtain an M mode at the level of the LA and the aorta. So this is the left atrium and the aorta, just to make sure there's no, dramatic abnormality like a very small aorta or a very increased left atrial size or much decreased left atrial size, which would be kind of a sign that there's underfilling of your left atrium, which would mean there's less pulmonary venous flow coming back. This is an M mode at the tip of the mitral valve in order to evaluate motions of the different, section of the left ventricle, as well as the, so if you see it cuts through here, you get the free wall of the RV or anterior wall of the RV, the septum, and the posterior wall of the left ventricle. You get the anterior mitral valve leaflet and a bit of the posterior mitral valve leaflet. We can kind of see it here, the anterior and the posterior. And we see it during the period of diastole of the left ventricle and eventually systole. And you can see that it's timed with the QRS. So when there's QRS, eventually you start your contraction, you get the peak of contraction, eventually you get the peak of filling, with kind of two areas here that are corresponding to the E and A motions of the mitral valve leaflets, where you have early filling phase from the early phase of the opening of the mitral valve and eventually the atrial contraction, which are followed by the similar kind of two ways of filling of the left ventricle. And so we can use that to look at some of the dimensions of the left ventricle or posterior wall or septum, as well as the RV. And you can look also at what we call the shortening fraction or fractional of shortening, which sometimes becomes very difficult to use as a marker of LV function when there is indeed high RV pressures, because you get paradoxical motion of your septum, which in this case is not so dramatic. So we're still able to see that you get a good difference between your LV internal diameter in diastole compared to the LV internal diameter in systole. And we get a shortening fraction of about 40%. So when we are, above 30, 35%, depends which textbook you look at, or which view you use, which typically are either the parasternal long or short axis view, and you really want to be, well angulated. Typically, 35%, that you have relatively normal LV systolic function. Caveats to that is that the shortening fraction is only at one area of the LV, and so you might be missing, segmental motion wall abnormalities. So then here we're looking at the RV outflow tract, the pulmonary valve, the main pulmonary artery. We can see or start to see some branching of the main pulmonary artery, and we can appreciate that there's a bit of a duct. It's this little flash of red that becomes red and blue, red and blue, red and blue, just by color. Here we have what we call a velocity scale or Nyquist, which will filter out speeds of blood flow that are below this value. So typically when we're looking at higher velocities, which are velocities of flow generated in arteries, for example, we use 77 to 90 a filter. And so you can see that there's blood that originates within the RVOT, goes through the pulmonary valve that opens nicely and feeds into the main pulmonary artery. And eventually you get this flow into one of the branch PAs, and you get ductus arteriosus that actually looks with, at the end spectrum with the yellow part, which tells me that the velocity are relatively high. And this tells me that the duct might be having some restrictiveness to the flow through it. And so there's a whole section in the PDA about what is kind of restriction of the flow. So you can go and read on it, but it tells me that obviously the flow doesn't pass through a very large channel. And so there's likely some tempering of the flow and of the pressure through this duct. And so here we get like a zoom on the pulmonary valve. We do see that there's inherently some trivial pulmonary insufficiency, which we kind of see often in babies. This is very physiological. There's no concern about this, but it's a good opportunity to try to get a continuous wave Doppler in order to get a sense of the gradient between the MPA and the RV. In this case, we did do it, but we didn't get a full envelopes, so I didn't post it on this website. So we put our cursor at the level of the RVOT, and we typically will get a pulse wave Doppler, which calculates the velocities of flow at the area that we're probing, and we're trying to be as parallel as possible with the flow into the main pulmonary artery, or at least into the RVOT. And here you can see that, there's a relatively, sharp uptake and eventually a bit of a longer kind of deceleration, which tells me there might be here a higher sorry, a lower pulmonary acceleration time to RV ejection time, which was the case in this particular case. I also see that there's some areas sometimes of what we call a mid-systolic notch, which is like a bit of a deceleration, reacceleration, and redeceleration, which could be signs of um, increased RV afterload. But otherwise, we see that the velocity time integral, which is the area under this curve of the velocity output of the RV, um, is not bad in the sense that we typically have these values in normal newborns. But once you compute what we call an estimation of the cardiac output, which take into consideration the measurements of the RVOT, the heart rate at the time of the pulse wave Doppler, this stroke distance, which this is really a stroke distance because it's the area under the time velocity curve. And take this into context of the weight of the baby, we get 130 cc per kilo per minute, which is relatively okay. We often say we like to have 150 and above, but values above 100 are typically acceptable in terms of output. So there might be a mild decrease, but nothing that seems to be too dramatic. We're not in, at 80 cc per kilo per minute. Ideally, 150 is typically kind of the normative value. So there might be a small decrease in the RV output in this patient. So now we're going posteriorly. We see some of the leaflets of the tricuspid valve open and close, and you see the right atrium and RV here. And we can see already that there's, during systole, or when the tricuspid valve is closed, there's a blue jet. So it tells me blood flow is going away from the probe. So it means the blood flow is going from the RV towards the right atrium. And you can see my line of cursor is trying to capture this speed, but I'm obviously not completely parallel. So there's at least 30 to 40 degrees. And I've put this example here because, when we probe TR, or tricuspid regurgitated jet velocity, we actually try to get it in every single view. But I wanted to show here how I actually try to move my probe and to be as aligned with the jet, but there's still a good 20 degree between my line and the actual orientation and source of this jet. But it already gives me kind of a velocity obtained of around, at its peak, of what we call 3.58 meters per second, which if you put in modified Bernoulli equation, you get about 51 millimeters of mercury of gradient between your right ventricle and your right atrium. So there's about a peak of at least 50 millimeters of mercury between these two cavities of gradient. In this context, I already know that this is underestimating, even if it looks like a complete curve. And that's, I think, one of the learning points for everyone out there. You really need to be parallel to the jet to get its full estimate. And we will see that in the upcoming views. And so 51 is a minimum, but it might be much higher than that. And people who would just be satisfied by that, you would probably underestimate the true value, because you really need to be as aligned as possible. So then we move into the parasternal short axis view. We start with the base, and then we go down towards we start at the base of the heart, and we go down towards the mitral valve, where we see a bit of this fish mouth, which is really the mitral valve, which is the anterior and posterior leaflet of the mitral valve. We see the septum in between and the RV on top that looks a bit juicy. And we could see a bit of the aortic valve in the middle here with the pulmonary valve here. So here already I'm, again, seeing here my left ventricle, my RV, and already you can appreciate the RV looks kind of a generous size, almost the size of the LV. And as I sweep down, I can even see that my septum is actually bowing towards the LV cavity. So already it tells me, well, there's at least iso, if not suprasystemic RV pressures. And I know there's no obvious sign of RVOT obstruction. So, this is not caused by a, congenital blockage. So there might be something downstream to the main pulmonary artery that is leading to this high RV systolic pressure. So in systole, when the RVOT is open and LVOT are open, you assume that the RV pressure equalizes with your PA pressure and that the LV pressure equalizes with the aortic pressure. And so you assume that whatever reflection you have between the RV and LV is the reflection between what you have in the great vessels in terms of pressures. So here we go and we do a sweep from the apex to the mid-papillary area. This is really at the mid-papillary area that we want to appreciate the septal motion, and not really at the mitral valve level per se. It's really at the area of the papillary muscle. So we see the two papillary muscle. So the septal wall is here, and you can see the RV that is about the size of the LV. So already I suspect that the RV pressure is quite high. Here I'm, doing a full sweep from the apex to the base. We can appreciate eventually also the pulmonary outflow, RVOT, the pulmonary valve, the aortic valve. We can even see a bit of the right coronary artery, and we obtain again, we're trying to be at the tip of the mitral valve and obtain M mode, and you can see that there's, really generous RV in diastole and even in systole in terms of diameter. The rest was pretty concordant with what we obtained in the parasternal long axis view. Here we've put some colors. So we see again this duct that is red and blue, red and blue, red and blue. So blue in systole, red in diastole, which tells me that PA pressure are higher than aortic pressure in systole, and that they're slightly lower than PA pressure, slightly lower than aortic pressure in diastole. And we see that this jet, has this kind of what we call aliasing, so very high velocities, which tells me that this duct has, already become a bit constricted and is creating some restriction to the flow, which, I'm not surprised to see that we don't have pre and post ductal clinical saturation differences, because the volume of blood flow going through this duct during the right to left shunting portion of the cardiac cycle is unlikely to be a huge volume of blood flow and unlikely to contribute to creating significant postductal desaturation. But we can see that we have nice branch PAs. We'll see it later in other views. We see the flow through the pulmonary valve, and here we obtain an actual Doppler where you see the right to left shunt component just after the QRS or during systole, and during the diastolic phase of the cardiac cycle, you see that there's this left to right, so the positive. So positive represents whatever appears as a red bicolor, which means coming towards your probe, and negative velocities is blue, so going away from your probe. So in systole, you get right to left shunting, and in diastole, you get kind of this left to right shunting. So you have about 10 to 15 millimeters of mercury of gradient between your pulmonary artery and your aorta in the right to left direction in systole, and it's unlikely to be underestimated because we know that the PTA is a tube and it's not a narrow opening, and so as such we don't satisfy all the assumptions of the modified Bernoulli equation, and so it's likely to be much more than 12. So if we're starting with a systolic blood pressure in the 60s, we have at least 12, here 12. I took about the average of the velocities, but you would take this one, you're probably even more than 12, you're probably around 15. And so, you're at about 70 to 75 millimeters of mercury in the systolic pulmonary arterial pressure. And the diastolic pulmonary arterial pressure is likely to be slightly lower than the diastolic blood pressure in the system. So here we're looking at the arch to make sure that there's no signs of obstruction. We have a nice arch opening. The flow was appropriate. We took Doppler in the ascending aorta, which looked within normal limit, which outlines kind of the output into the aorta. Same thing, we look at the velocity in kind of the descending aorta to make sure there's no signs of acceleration and there's no signs of gradients, because we wouldn't want to miss a small arch or like hypoplastic or interrupted or coarctation. Same thing, we look at the descending preductal aorta and we don't see any big differences between the pre and postductal levels. We then looked at the aortic valve. We can see the right coronary artery, and we can see it in motion here, as well as some of the, left coronary artery origin and branching. If you're in cardiology, you would want to use very low Nyquist in order to see some of the coronary flow in diastole, and we see in red here occasionally. Why? Because the coronary blood flow occurs in diastole, and it's usually at very low velocity. We can even see the flow in the right coronary artery, and it's not unusual to see that babies who have had acute pulmonary hypertension, which they have often sometimes some degree of increased right atrial pressure, while they end up with more juicy coronaries, I would say. And the reason is that the coronary system will drain via the coronary sinus into the right atrium. And so if the right atrium is under a bit of a higher pressure, you get a bit of distension of these coronaries, which sometimes could also be related to vasogenic substances that the baby will be secreting, which are thought to promote coronary dilation, to promote coronary blood flow. So maybe some downstream ischemia to the myocardium that promotes this kind of autoregulation mechanism. So again, we see the PDA here along its course, which is red, blue, red, blue, red, blue, and looks quite restrictive. We then end up in our 4-chamber view, so a bit of a focus on the RV, where we see here this blue jet. So first, we see the red, which means that we get good inflow for filling of both ventricle. You don't want to miss mitral or tricuspid valve stenosis, for example. And you want to see if there's like significant mitral insufficiency, which could raise your left atrial pressure and cause a post-capillary component to the disease, which doesn't seem to be the case here. We even see a bit of one of the pulmonary veins. So this is the left lower pulmonary vein. We see kind of the flow coming here. And then we see that there's blue jet. This blue away from the probe is in systole and represents, some mild to moderate tricuspid regurgitant jet. It doesn't seem to reach the roof of the right atrium, and the right atrium doesn't seem to be very distended. So we wouldn't be able to call it a severe TR. And even typically moderate TR is when it reaches close to the roof of the right atrium. And when you start seeing dilation is when you have severe, or when you start seeing that there's retrograde flow in the subhepatic veins or IVC and SVC, that's when you start calling it quite severe TR. So here we would call it probably mild to moderate. It's not a very objective classification, sadly, but this is what we use in the newborn pediatric period. There are in the adult world some ASC guidelines about how to quantify valvular insufficiencies, but they have never been much applied into the neonatal period. So here we see the RV, the LV. In general, the LV function looks adequate. We can see the tricuspid valve, which is a bit lower in terms of its placement compared to the mitral valve. This is completely normal. So we know this is not like an AV canal. There's always going to be a component of right atrial to left ventricular septum, this minimal area here. So this conformation looks within normal limit. And so when we look specifically at the RV, we see that it looks, still muscular. It has kind of a non-compacted appearance, which is expected for the right ventricle compared to the smooth appearance of the LV. And we can see, the motion of the tricuspid valve, which looks quite good. In this particular patient, the fractional area change of the RV, which is the fraction between the end diastolic and end systolic area, and you would be able to find it on the website under a right ventricular function. This our RVFEC was around 28%, so slightly decreased, but the TAPSE was within normal limit. And I think I have an example of the TAPSE coming very soon. This is the 2-chamber view of the LV. We see the appendage of the left atrium, the mitral valve. We see the inferior wall of the left ventricle and the anterior wall of the left ventricle. And we see that the LV in general has a good squeeze. And the Simpson biplane was within normal limit. I think, we had 64% of Simpson biplane. Again, with color, a little sweep to start seeing the LV outflow tract, make sure that there's no obstruction, especially in the context of the infant of diabetic mother. So we want to make sure there's no septal hypertrophy leading to LVOT blockage, which is a hallmark of very severe diabetes during pregnancy. We take Dopplers in the LV inflow, where we see the early phase of filling and the active phase or the atrial contraction phase of filling, and typically in the early part of the transition of a newborn. The E peak and the A peak are very similar in terms of velocities, so it's not unusual to see similar velocities or slightly higher early or slightly higher late or atrial, and that tends to fluctuate with time. So we don't have great normative value for that, and you can see it more on the RV side where you have some cycles where the early velocities are much lower than the atrial kick compared to some of the other cycles. But at least we see that the velocities are not extremely high, which would make you consider that there might be some degree of mitral stenosis or acceleration there. So this is a sweep from the four-chamber view, eventually to the posterior coronary sinus, anterior, and then we see the two outflow tract. It's quite quick. We see coronary sinus in here, and then eventually quite a sweep towards anterior with the LVOT branching here, and eventually the RVOT branching even more anteriorly here. So this is the TAPSI. We have our line of interrogation that attempts to cross through the apex and goes to the free wall of the RV at the level of the attachment of the tricuspid valve. And here actually the motion, which is here, was measured to be 1 centimeter, which is normal for a term baby. So it tells us the systolic RV function looks relatively preserved, although the FAC, which is another marker of systolic function, was slightly diminished. So here you see this baby has had an arterial line. So I took the blood pressure at the time of what we call my TR evaluation. And here you have a tricuspid regurgitant jet. You have the tip of the curve here, and you get an RVRA of 4.95 meters per second, which gives you 98 millimeters of mercury. So you can see that, if you add the expected RE pressure, you would get a peak RV systolic pressure, which you assume to be the same as the peak pulmonary arterial systolic pressure. And so we have about 100, 105 of RV systolic pressure compared to about 51. So we're clearly suprasystemic here. And if you would have taken the previous TR, which was not aligned with the TR jet, you would have had assumed that the RV pressures were much lower than that. So that's why, that's my plea towards always making sure that you try to obtain the best evaluation, knowing that this is highly dependent on the angle of insonation that you're doing during your echo. Here we're looking at inflow from LA to LV, eventually into the RVOT, and into the LVOT, through the aortic valve and into your ascending aorta, making sure that there's no signs of obstruction, no signs of acceleration, which could be seen if you had hypertrophy of your LV or septal hypertrophy, for example. It's a good place to obtain a Doppler at the level of the LVOT. Here, the LVO estimate, which is the same concept as the RVO estimate, so measurement of the aortic valve and measurements of the LVOT diameter in the parasternal long axis view, heart rate of 110. Typically, we like to take the heart rate of 1 cardiac cycle, and then you do your VTI. And here, we estimated the VTI at 165 for the LVO. And so that's very normal, so above 150. So relatively preserved LV output. Here we obtain a pulse wave Doppler at the level of the inflow-outflow, which helps you calculate something called the isovolumetric contraction, relaxation time. So you have here your early filling, your atrial kick. Eventually, after that, you get your QRS, you get your systole or LV ejection into the outflow tract. And then eventually you get a short period of time here or here, which is a period that we call the isovolumetric relaxation time because it's just before the relaxation or IVRT. This is a modified view or the TED view, or what we called the anterior posterior view of the RV, or sometimes it's called the RV three-chamber view because you have the right atrium, the tricuspid valve, the inflow portion of the RV, the body, and the outflow portion of the RV. We obviously here, we can see it in 2D. This view is good to appreciate the motion of the inferior wall of the RV, which sits posteriorly in the chest, as well as the anterior wall of the RV and its connection to the RVOT and pulmonary valve. It's basically using the two-chamber, orientation of the probe for the LV and then sliding towards the sternum. Great view sometimes to see some of the TR jet and be well angulated. We see it here. For function, it's been used to kind of calculate fractional error change. So it's a good view to get a global sense of the RV function, but don't forget that the most contractile area of the RV is not necessarily the posterior or anterior wall, but it's a contributor of all the walls. But in many animal models, it's the lateral wall and the septal wall that seems to contribute the most to the contraction of the RV. But typically, if you have global RV dysfunction, you would see this dysfunction also appear in this view. So we see that there's output, with a bit of pulmonary insufficiency here. So this trivial red flow when the valve is closed, and we can see there is mild to moderate TR in this particular patient. Then we go into the subcostal view. So we have liver here, right atrium, left atrium. We can even see a bit of a pulmonary vein entering the left atrium in 2D. We see the mitral valve with its papillary attachments, and we can see even a bit of the papillary muscle attaching to the LV free wall, and there's never attachment of the mitral valve towards the septum. This is very particular of the LV. And we can see that there is a PFO with a flap. And here we can see that the shunting direction is partly left to right, partly right to left. So red, blue, red, blue, red, blue, red, blue, telling me that the PFO is also bidirectional here and informing me that the RA and LA pressure are kind of similar, which is not unusual to see in the first 24 or 48 hours of life. Most babies will have a bidirectional PFO. And it doesn't seem that the shunting volume, at least from a subjective evaluation, is significant in terms of a right to left component. So here another view, but this time we do the full sweep. So we start from the RV anterior outflow tract, and then we go more and more towards the atrium. So RV here, outflow tract here. Eventually, we see the LVOT and the LV, and eventually we see the two atriums. We even saw the SVC kind of entering into your right atrium here. This is the SVC. Now we are going into the short axis view because it's the short axis of the ventricles. So we see the two atriums here, SVC, IVC, bicuval view. Here we see the LV in short axis with the two papillary muscle. Eventually we go back and we see the RV towards the RVOT. So it's a great view also to assess RV function and output. Many cardiologists will use that to assess patients with TOF because you get to see nicely your RVOT. Here we obtain Doppler into the SVC to make sure there's not a lot of retrograde flow into the SVC, especially if you're concerned of high RA pressure. And then here we're getting a Doppler in the subhepatic vein. So this is a vein coming and draining into the IVC. And, you would expect a lot of negative flows or blue flow because it's going away from the probe to feed into the IVC and to have a bit of to have a bit of retrograde flow or red flow is not unusual in babies, especially if you're pressing a lot with your probe. Here we get the aortic flow. So I was trying to get a Doppler, which I didn't show you here, but it was completely normal in the descending aorta. And we do many scans at a bit of a lower Nyquist in all the views of the septum to make sure that we don't miss a VSD. It's very easy to miss a VSD in patients in the first few hours of life, especially if small, because you have relatively similar, PVR and SVR or pressure into the RV and LV. In this case, we would have likely seen a right to left shunt during systole. So you don't want to miss that. So we didn't appreciate any VSD, but it's definitely something you need to reinterrogate as the baby age, especially if you're doing an echo from a pediatric cardiology standpoint. So in TnE, we don't necessarily, we're not the experts of congenital heart disease, but we don't want to miss one and then not notify our colleagues for an in-depth evaluation by the cardiology team. So here, it's a great other view to get the short axis of the LV, and you can see kind of the papillary muscle of your LV, and you see your RV here, and you see how the septum is also bowing towards your LV in this short axis subcostal view. See the liver here, and we see a bit of the lung into the background. There's something I wanted to show that I don't want to forget. If I'm able to show again. I had seen it pass at some point and I thought of describing it, but then I forgot to describe it. It's when looking for VSDs. So I didn't show the scan of the whole septum, but we scanned it in parasternal short, parasternal long axis, apical view for ruling out signs of VSDs, obviously. But sometimes there are little flows that can be thought to be a VSD and they're not necessarily a VSD. And they're actually little coronaries or coronary flow. Like for example, here, this is often like a little coronary flow. Yeah, perfect. Okay, so then this is SVC flow, LA, RA, and we also see there's a bit of a bidirectional flow through the PFO. This is another view of the PDA. Now I'm getting into my pulmonary veins. So first, here we see again the aortic valve, the left atrium, and we see one pulmonary vein here in red with a relatively lower Nyquist, and we see that this pulmonary vein drains into the left atrium. And here we're Dopplering, and so we see that there's like 2S and then a D wave, so SSD for diastole. So normal triphasic low velocity pattern. We see another one here in blue, red, and then blue here, and we Doppler it, and so we also see, and because this baby is on high frequency, sometimes you can get artifact of motion. Then we go to the other side, we see a blue one here and a red one here. So we Doppler the one that is red. So the lower pulmonary vein, so two lower pulmonary veins, lower left, lower right, upper left, upper right. And then same thing, we Doppler this blue pulmonary vein and we see the negative kind of velocities because they're blue or going away from your probe. So there doesn't seem to be any concern about the pulmonary venous drainage. We then look at the caliber of our pulmonary arteries and we Doppler them to make sure there's no significant acceleration that would, make you think of an obstruction of either the, RPA or LPA, which could contribute to some degree to increase in the MPA pressure and into the RV pressure. So this patient had very high RV pressure, suprasystemic, relatively or slightly decreased RV function, slightly decreased RVO, maintain LV function, maintain LVO, a PFO that was bidirectional, PDA that was bidirectional, and no other signs of structural concerns. And so, really makes you think of high pulmonary vascular resistance, especially in the context of the story. And because of the very high oxygen needs, at that point, we were a good X-ray of expansion, good ventilation. The baby had already been, exposed to some degree of, making the baby calm with a calm environment and making sure the baby's not in pain. And obviously this particular baby, there was possibly a concern that, of a perineal infection. So blood cultures were sent, antibiotics were initiated. And so at that point, based on this assessment, the decision was made to start INO. And the baby had an immediate response with a rapid drop in the need of FiO2. So that's, during the actual TnE. And what we see here is the duct at very high velocity and looks again bidirectional. And that's just a few minutes, but you can see that you're spending quite a lot of time left to right and really just briefly right to left. And I froze it during systole and the right to left. And so we were getting 0.2 and in diastole, we were getting 0.18. So it's probably around a 0.18, 0.2 centimeter duct. And here you can see that the right to left component already dropped to 5 millimeters of mercury, so still a component of right to left. We looked at DRV. The RV function looked a bit, more vigorous, just subjectively, and the FAC actually here had increased to 35%. And eventually I came back a few hours later, like 3 hours later, and at this point you can see that duct is now completely, first of all, very small, looks like a little flame. Um, and here you can see it that it's, very obviously red throughout the cardiac cycle. And when you actually Doppler it, you can see that is red throughout the cardiac cycle. So it tells you that the pressures have gone down. So went from a suprasystemic to about a bit infrasystemic, probably, in the isosystemic to infrasystemic range, but we still had about 10 millimeters of mercury of left to right in systole compared to diastole. So telling us that, in systole compared, and this is diastole, you see it here. So this patient was, about a few points below the systemic systolic blood pressure. So definitely a response in terms of dropping the RV pressure and the PA pressure. So I've put here some of the consideration of the management if in PPHN or acute pulmonary hypertension. This is the basic knowledge that I think every neonatologist or trainees in neonatology should have to the management of these patients. It's a very global and comprehensive evaluation of these patients. So of course, good diagnosis, good evaluation, good assessment, good monitoring are critical and essential. You don't want to consider things like, this kid is at risk of hypoglycemia. You don't want to have hypoglycemia, so you want to manage that. You don't want to have hyperglycemia either, so you need to monitor it. You need to make sure that, the baby's not seizing if there was a component of HIE, because this can create stress and increase your PVR. And then you want to assess, like your pulmonary management. So, is surfactant something that's been considered if there's very low recruitment of your lungs or high, mean airway pressures in order to maintain pulmonary recruitment. You want to optimize your pulmonary recruitment while still not over distending your pulmonary parenchyma, because over distension and high mean airway pressure can also first of all, increase the pressure in the alveoli and squish your pulmonary vasculature, but also restrict the venous blood flow coming back from the brain via the SVC due to the high intrathoracic pressure, which can underfill your right atrium and create venous hypertension in the brain. So that's something you want to kind of balance out when you're increasing your mean airway pressure. Sedation and analgesia, we tend to use very minimal doses, or we don't want to have a baby that is comatose. We just want a baby that is comfortable and avoiding any kind of reactive increase in PVR, especially when we do cares and manipulation that we actually try to really cohort among health professionals in order to be efficient, but also very delicate and gentle with these babies. You want to keep an environment that is, without noxious stimuli. So a darker environment, quieter environment. Sometimes even we have some music for some of these babies that are either through music therapy that is tailored to the condition, or even we put sometimes classical music when we do our echoes, and we find it calms down these babies, although there's probably no great data on that. And so oxygenation needs to be optimized, but there is a point at which too much oxygen might be toxic. And so you need to titrate it in order to achieve the best response. But once you don't get more response, there's no point of just increasing the oxygen. If despite that optimization and you still have a physiology of PPHN, like in that case, well, we strongly advocate to get some echo evaluation to confirm the actual suspicion of the diagnosis and really get some hemodynamics information, because you don't want to miss, for example, a severe LV dysfunction or a post-capillary vascular phenotype. And so in this context, INO has been the only studied agent in RCTs in the context of hypoxic risk failure, which is often thought to be associated with acute PH or acute PPHN and some of these term and near-term newborns. And it's been shown to decrease the rate of ECMO in these babies. And so we tend to wean as early as possible in these patients of that. There's increasing data that some of the vasopressors, like vasopressin and norepinephrine, may improve your PVR to SVR ratio if you do not respond to INO. So in this context and in this particular case, we did not need to start these medications. Rarely you need to have PGE, especially when the duct restricts and you start seeing that the RV is going into failure. In this particular case, we did not need to reopen the duct because the RV was relatively vigorous and that it actually normalized in terms of function once INO was initiated. And sometimes in very severe cases, you may consider other adjunct therapy like hydrocortisone, RV inotropic support, and sometimes even ECMO in some of the babies that are quite severely ill and do not respond to the medical management. So you will find some of the review of the physiology here, and you will find a whole section under TnE and pulmonary hypertension that has much more resources. I thank you for listening to me and to this case. I hope it was instructive and informative. And obviously, this is just in the purpose to provide educational material. Then you need to obviously take every case you encounter with the particularities of that case and in a multidisciplinary fashion within your own setting, your own resources, and your own evaluations. And of course, tailored to your own protocols of practice. I do invite everyone to actually go into the case of the month. And then if you have cases that you would like to share with our community, you'll find a form here to fill out to provide a case of the month, which can be here also. You can just click and open, and then you can submit files with obviously anonymized with no identifiers. And ideally, you should also provide a form for the family to be aware and to potentially sign that they agree. But the most important thing is that there's no patient identifier and that it's obviously anonymized. And then the other thing I'm going to, take the opportunity that we do have in the news section a survey. So if you have time to fill out the survey, it's about 10 minutes. You can even open the survey in a new link, which talks about the NeoCardio Lab content, and we're trying to better understand who are the users, how does this platform provide educational resources that you enjoy or least enjoy, and if you have suggestions for us to be able to tailor the content to educational needs that you may have in your context. So thank you for following, and I hope that this was informative.